Good day, listeners. Welcome to Mind the Gap podcast. We are exploring the cutting edge technologies in oral health. My name is Dima, and I'm today's host. Today with us is Dr. Saleh Aria, who is an implant dentist and principal of the Hornchurch Dental Practice in Essex. Dr. Aria has extensive experience in using lasers. He has a mastership degree from Aachen University in laser dentistry, and he has been lecturing widely around the world about this technology. So welcome, Dr. Aria.
Thank you. It's a pleasure to be here.
Thank you. Thank you for coming. Dr. Aria, I would like to ask you a rather personal question. So tell us about your life journey. You have been in so many places. You have started practicing dentistry in the UK in 1999. Tell us a little bit about your journey.
Of course, absolutely. How long you have got?
How much you need?
So, as a growing up in a young boy in Sweden, Stockholm, I started being interested in education, of course, going to university, and I started going to dentistry. Probably my father was one of the reasons pushed me to the dentistry. However, after I qualified in Stockholm and I did come to UK for 6 months work experience, here we are. I'm still in UK after 6 months. It's not finished yet.
No, that's such a common occurrence around the people that end up in the UK.
Yeah, that's right. So, yes, as my father told me, so I have to be a surgeon. And then I started looking for dentistry, and then I would like to be a surgeon. Please, my father just. But today I do enjoy the surgery as much as should do.
Do you have dentistry running in the family?
Yes, my older cousin was a dentist, and it probably was an inspiration for me to become a dentist as well. Yes, that's correct. So then I started specializing with the implant, and then I was looking for something minimally invasive treatment, how I can treat my patient minimally invasively. So then I started looking for laser dentistry. And as I did go for normal courses, day courses, or weekend courses, but I thought this is not enough for me. I wanted deep. So I want to understand why, how I can I can treat the patient minimally invasively. Therefore, I did go to Aachen University and did get mastership there. And I really enjoy that laser dentistry, because I know how much my patient can enjoy it, my patient can benefit it from that. That's my journey started.
Fantastic. So when was the first time you got in contact with the laser technology? Is it after university, I suppose, because they were not teaching it in university as
No.
they don't do it today?
Unfortunately, universities, especially undergraduate, they don't teach at all laser dentistry. Some postgraduate, very numbered universities talking about that. Most probably they're not, most of them. I just started probably 10 years ago. So I started looking for laser dentistry.
Were the lasers already an established technology back then, 10 years ago?
Indeed, it was. And it's been a long time. For example, YSGG, erbium chromium YSGG laser, which is a water laser, has been FDA approved 2002, I do believe. So it's been a long time.
That's a long time indeed. Let's start with addressing the elephant in the room.
Sure.
A lot of people that are not using lasers, and that I'm asking them about why would somebody use a laser? The question is, why would somebody use a laser if they can do everything that they need to do without a laser? So the question, I suppose, is, are there any procedures that you can do with lasers and you cannot do them with any other means?
Absolutely. So, of course, we can use a laser for everything. What we have to understand, laser is not replacing dentistry. Laser advancing minimally invasive treatment. Let's talk about what I do daily for laser. I use a laser mainly for soft tissue. I do use a laser for periodontal treatment. I do use a laser occasionally for restorative dentistry. Of course, I'm not a restorative dentist, but sometimes I have got some patient which would like to do. We can use a laser for endodontic treatment. We can use laser for implant treatment. We can use for basically photomodulation, pain management effect. Let's talk about soft tissue management.
Okay.
So imagine we do in just simple way, frenectomy, right? Sometimes we do need a frenectomy, gingivectomy.
Is it often that you find patients that come in with a need of frenectomy?
When especially diastema happens, when the tissue retractions happen because the frenulum pulling the soft tissue away and recession happens, that is inevitable. You have to get rid of that frenulum. You have to release the tension. When you're releasing the tension, when we're using scalpel, what happens then? We have to cut, right? Then we have to suture up. Suturing up is time consuming. You have to basically give a scar when you cut him with a scalpel. When
You don't get a scar with the lasers?
No scar with the lasers because we're not suturing up.
Mm.
And then another thing is when we cut him with the scalpel, immediately inflammation starts, right? Blood gushing out. Inflammation means what? Inflammation means pain. Inflammation means swelling, edema. When we cut him with a laser, those small blood vessels immediately coagulates. What that means? So we have a better visualization of the surgical field. And secondly,
So there is no blood?
no.
Or very little?
That is a wrong word, say no blood. It's a less bleeding.
Less bleeding.
And which I will come to in a minute second for that one as well. So less bleeding. But when is it less bleeding? Immediately we coagulate in those small blood vessels. That means so we eliminating less inflammation. Less inflammation is going to be less pain, less edema, less swelling. Of course, we have got water lasers. Especially in this case, we're talking about erbium chromium OSGG laser 2780 nanometers. This laser absorbs 300% more than YAC laser, which is a 2940 nanometer. What that means there's going to be deep penetration, less bleeding. So therefore, why we call in all tissue laser? All tissue laser, which is in this case erbium chromium OSGG laser, absorbs strongly in water and hydroxyapatite. Therefore, can cut both hard tissue and soft tissue. And less bleeding. Often we don't need too much anesthesia. And basically less pain and more comfort for our patient. Let's talk about periodontal pocket. Why are we using a periodontal pocket? Because eliminating basically more for bacterial colony, which will help minimize bacterial colony in deep pockets. Of course, we have to use conventional treatment as well, in combination root planing, scaling. So when we're using lasers, so we eliminating the bacteria, which is more healthy, more environmental, more biological, basically, cleaning disinfecting the socket. Let's talk about endodontic, for example. We know then why some endodontic treatment fails because of the bacteria, right? Because the anatomy, difficult anatomy of the root. And we do know sodium hypochlorite, for example, disinfectant, penetrates to 100 microns of dental tubules.
Horizontally?
Yes. And then, as we know, bacteria like Phocalis albicans, they penetrate up to 800 micron in dental tubules. And we know our lasers, studies showing us, they penetrate up to 1,000 microns. So it's a very simple, it's no rocket science. When we have got difficult anatomies like isthmuses, delta-shaped lateral canals, we cannot clean all of them, especially when we creating smear layers, when we prepping them with the rotary instruments, we creating smear layers in dental tubules, bacteria in dental tubules, and we pushing those smear layers into dental tubules even deeper. So there is no rocket science. Something extra we do need when is a complicated root canal anatomy, or persistent infection. So that is we using for that. When we're talking about implant, of course, we doing immediate implant placement, for example. What we doing? We taking out the tooth which is infected. Otherwise, we wouldn't take out any tooth, right? Infected tooth means has a bacteria in the around the periodontal ligament.
Which is a direct contraindication of immediate implant placement.
Indeed, absolutely. So when we using laser, we selectively and precisely we removing what we need to.
When you say selectively and precisely, what do you mean?
Imagine we're using rotary instruments,
Yes.
a drill.
Yes.
Get rid of the older granulation tissue. What we doing? We not only removing granulation tissue, we removing some of the bone, which is a very crucial for our implant placement. Secondly, we creating a smear layer. Those smear layer, which is infected tissue, and we again put in for bone trabecularies. So something extra we do need here to clean properly. So therefore, some of our colleagues' immediate implant placement might fail.
But didn't you mention that the laser, the YSG,
YSGGS.
it does also cut, is an old tissue laser, so it cuts also the tissue, but also the soft bone. How you selectively clean all the soft tissue, the infected soft tissue, and you don't, let's say, touch the bone?
Of course, with the hard tissue, we no contact. With the soft tissue, we in contact mode. So therefore, we can cut all the granulation tissue away. And then now starting selectively ablating away all the infected bone material, which is beyond the granulation tissue, right? So therefore, we can disinfect. As the laser has got the bactericidal effect, single oxygen, which is a very toxic. When you divide in water with the hydrogen and singlet oxygen, that singlet oxygen is our tools, basically disinfecting toxic and eliminating all the bacteria away.
You were talking about periodontology, but I suppose the same will apply also for peri-implant disease, right?
Indeed. So when we're talking about peri-implant diseases, what we have got, if we compare a normal root, Jason root with implant, normal root is a smooth surface. We can root plane. We can take out all the first layer of the smell layer. But when we're talking an implant is a thread. We can't, unless we smoothing all the threads away. What we creating then? We can't go deep those small pockets, which is about 500 micron, 600 micron might be, between the bone and the last thread is exposed. Secondly, when we drilling implant threads away, what we creating? We creating titanium tattoos as well for our patient.
Oh, that's true, right.
And aesthetically, we're not getting nice results. And then we try and augment that, which is covered with titanium tattoos, covered all the bacteria, which is splashed to the bone, and we try and put in the bone material there, and then that's not working.
And you don't have a surface. You don't have a rough surface anymore.
Exactly. So we don't have a rough surface, which we do need to get. And then we say to patient, okay, now you have got the smooth surface, you have to clean up. Let's look out of the box. If we could clean with those threads, which in especially old tissue laser, erbium chromium YSGG laser, has got unique tools, which is side foreign tip. That side foreign tip directly energy of the laser directed to the threads. Thread by thread we cleaning, and then of course we have to augment with the lost bone. And sometimes we don't need to open there, which I do a lot. I don't need to open there or raise a flap. Thread by thread we cleaning, like we would do the root canal treatment, with the root surface. And then giving less, eliminating bacteria, so the bone starting regenerating by itself. Depends how many threads are being exposed, of course. If it's too many threads is exposed, there is a bit too much asked, might be.
Fantastic, very interesting. So the question is, the laser carries obviously energy. How does this energy affect the surface or the metal of the implant? I mean, does it not change the topography of the implant?
Not at all. Study showing us that even cleaning the laser, because there's no contact point, of course, everything, as you mentioned, energy. So we can't give too much powerful energy to the metal surface, or even the bone, or even the tissue. So therefore, we cannot be a button pusher, just to put. We have to understand. If we go into seaside, right, and we have a white sand and we have a black sands, which one will be more hotter?
The black sand, obviously.
Absolutely, because absorbs all the energy and keeping that. White sand is reflecting, right? So exactly the same. We have to understand the tissue interaction with the laser. That's the important part. Some of the colleagues don't understand. Just pushing the butter.
Does this apply, for example, to selectively getting rid of decay, tooth decay?
Indeed. We can use for restoration, for example. Depends on which class of the restoration we're doing. Are we doing class 5 or are we doing class 2? If we go and do, for example, MOD restoration, we go and cut the enamel. We go and cut the dentine quite deep. And again, when we cut in with the laser absorbs in water and hydroxyapatite, right? Caries has got more water than normal dentine. When ablating with the laser energy, those caries which has got more water is a softer, easily ablated. Of course, we will use a conventional, might be with the excavator, remove the major part, and then disinfect all the dental tubules, which is a bacteria trapped inside.
I wish my dentist had at a time a laser, because this is how I ended up having 2 crowns instead of just simple restoration.
Absolutely. I wish myself when I was a child, someone used the laser when they did the filling for me. And a study showing us, again, when we're doing the crown, with all the vibration, microfracture happens for the, enamel and dentine. After 10 years, most of the crowns will end up with root filling. Again, let's look out of the box. If we could remove those small decays selectively, this is what I mean selectively. When we cut in with the drill, we're removing too much of the tissue. We have got the bigger drill. Now we're talking about probably 600 microns, 1,000 microns and 1 millimeter, right? We're talking about 600, max 800 microns fibers we're using. Those selectively ablating away without touching the hard tissue, which is in this case, hydroxyapatite.
Fantastic, very interesting. So it seems like the lasers can have a wide use in a dental practice. So let's take it to a personal example. So you have been using lasers for quite some time. So how, as a percentage, how much of your procedures in day-by-day practice you can use the lasers on, and how often do you use them?
You should ask when I don't use a laser.
Well, that's a better question.
So today I don't know how I can do old way conventional laser, conventional treatment. Every single day I'm using laser.
Let's pick one indication. Let's pick one indication which changed dramatically your life and your patient's life just because you can use a laser now.
As an implantologist, I do a lot of the implants. I do treat the pre-implantitis and then mainly immediate implant placement. Let's talk about immediate implant placement. Why patient would like or why we would like a place implant immediately. We preserving the tissue, right? When we preserving the tissue, so therefore, biologically, of course, lasers not replace the grafting, making right environment, right biological field for our augmentation, for soft tissue augmentation, and immediate loading, of course. After we extracted traumatically a tooth, we disinfect it, we removed all the infected tissue, and then we place an implant, right? we get in primary stability, especially with immediate loading. Gap between the implant and the buccal bone or junk bone, we have to fill up the gap junction. But what I used to do in the past, and most of our colleagues doing today, we place an implant directly where we prep our implant bed. When we prep an implant bed, we create a smear layer, right?
Yes.
Study showing us those smear layer, which is a microscopic between the bone and the implant, that smear layer is going to take 6 to 8 weeks to body get eliminated. Again, if we look out of the box again, if we could get rid of those smear layer immediately, what would happen? Our implants immediately direct contact with the bone. Osseointegration started immediately. Therefore, we're saying osseointegration starts after 6 weeks because smear layer there. So body has to get rid of those smear layer first before osseointegration happens. But if we could get rid of them, immediately starts. We're using soft tissue with immediate implant placement, especially with the buccal tissue. We have to get, when we have got a very thin biotype, so we have to replace the tissue. Yes, we can go get the connective tissue. We can do what's the free gingival graft, and then we can deepitalize those free gingival graft. Taking out free gingival graft and deepitalize it on the piece of gauze, glass, or wood is quite difficult, especially you taking what? 4 or 5 millimeter tissue, 6 millimeter tissue. But imagine, we could deepitalize before we cut in the tissue away.
Well,
how simple is it?
That would be very simple.
So then we place in the tissue function, and then we replace in the biomaterial of choice for the gap junction, and then we start in. So placing the immediate loading. So that means, so no pressure, and we build enough minimally invasively. And that free gingival graft I'm taking nowadays, I don't use any sutures. I just a laser bandage. Why? Because laser coagulates those small blood vessels from the palate, which would be bleeding.
So, which means also the patient is in less pain after harvesting the graft, right?
Absolutely. Absolutely. What we used to do, we used to use collagen. We used to do sutures. All this time-consuming. Time is money, my friend.
That's true. So how about your patients? Do they love it? Do they love knowing that their dentist is using laser technology? I mean, we all being in some way still little kids inside, so we think of lasers, we think of Star Wars. So I suppose when people come and see that you are using laser technology, they start asking already questions. So what is the expectations from somebody that says, I'm going to use a laser on you?
When we use the hair laser, immediately we used to think about eye, right? Eye surgery is the laser.
Yes.
If we can trust ophthalmologists, they can do for laser our eyes. So that makes us more calm because eye is a more sensitive. Eye is the king. If we can't say we are lost. But when you're talking to patient, I'm going to use a laser. Immediately releasing that tension, anxiety, because they know laser will work. So when I'm saying to my patients, I'm going to do immediate implant placement, which you wish, and I'm going to use a laser to extract minimally invasively, atraumatically, and then place implant. And before you go in home, you're going to have your temporary restoration. They love it.
Fantastic.
Because they know this will work. Because either themselves or someone, friend and family, they had eye surgery with the laser. They know it does work. It's not harm.
How exactly using the laser for automatically extracted tooth?
Okay. So when we extracting the tooth, what we're doing? Breaking the periodontal ligament between root and the
Bundle bone,
right? So when we put in a pressure, so microfracture happens on the buccal bone, which is often 0.79 millimeters. If we're picking up 10 people from the street, probably 8 of them has got less than 1 millimeter bundle bone. We put in a pressure to bundle bone and macrofracture those bundle bones. What happens then? We needed those bundle bone to be able place implant, build a junction between the gap junction between the bone. But when we using laser, using as a periotome, I use a laser as a periotome, basically breaking the periodontal ligament. With a small pressure, I can atraumatically remove the tooth and keep those very fragile bundle bone. That helps me a lot.
Fantastic. So from the patient's perspective, did using lasers in your practice bring you more patients? Did it affect your business at all? Did it help you from a marketing point of view?
Absolutely. So when you use a laser, who's using laser is going to be top of the other practices selectively, because the patient talking about laser, even talking about to going to friend and family and say, I had the treatment done with the laser, is fantastic, isn't it?
Well, especially if there was no pain involved afterwards.
Indeed. And some of the laser treatment, even sometimes we don't need to use anesthesia. Anesthesia is a more anxiety for patient. Especially I don't do so many fillings, but I do.
Pediatric dentistry, I suppose it can be very useful. I know because I've got 2 little boys and it's one of their biggest fears, going to the dentist. And with one of them, I had this traumatic experience, as probably every kid does at some point in life. We were in a foreign country and we had a problem with one molar, so we had to go out and take it out. And it was a terrible experience. I mean, the whole extraction took, I don't know, maybe 1 hour and something, and it was constant trying and trying and trying. And in the end, I encouraged him as much as I could, but he was still in tears, and it was breaking my heart to see my kid having this first interaction with a dentist. So next time when he had an issue and we had to go to the dentist, his baby teeth were not coming out, so we had to take him out. So he was still under the trauma of the bad extraction. So I made sure that I set him with a laser dentist, which we have a laser dentist close to our area, and I told him we're going to use a laser, so it's not going to be painful. He accepted so much easier, even if in the end it was no need for the laser because it was very easy, right? But still, it gave him a comfort of mind that it's going to be an easy extraction, and he trusted me. And I think from now on, whenever we'll ask him to go to a dentist, he'll probably require going to see a laser dentist.
Dima, tell me, who wants injection?
Even I don't like them. I don't
Nobody
know. And
does.
I've gone
Nobody
through
does.
massive restorative procedures and orthodontic treatment, so I had lots of them. I always hated them. Okay, you're an adult, so you just tough it out, right? But you don't like them.
As a professional, we would like to be the best dentist in town.
Yes.
If I'm going to use old technique, conventional, how I can say I have got the cutting edge technology, modern dentistry, and still use all the same black and deck drills?
I suppose some people just are afraid to do no harm, as this is the fundamental thing in medicine and dentistry. So I suppose they either think that it can be harmful, which will bring us to the next topic, the regulatory basis of this, or just because it's a price, or because discussing with you at this leisurely environment, it seems like it can do a lot of things, and there should be any reason why a lot of people should use it. But still, what is your approximation on how widespread is laser dentistry in a, let's say, country like UK, where we have got 40,000 registered dentists? What is the percentage, average percentage, let's say, of penetration of laser dentistry among the UK dentists?
About, I would say, with my experience, 10% of the practices has got the laser.
And are we talking about laser or diode?
I'm talking about mainly diode may they have. Water laser is less. Then about 10%, but doesn't mean they're using regularly. They're using every single day. They have got there. Therefore, I will always say to my nurse and who I'm teaching as well worldwide, I'm saying your laser should be on every single morning. Is it ready to use? If you go and say, I wished I had a laser set up, I could use it. I will use it next patient will never come. Because that laser might take 10 minutes or so set up. We dentists always rush in. We dentists always want done quickly because our next patient might sit in and waiting, right? But when using, that comes to oral surgery and implantology, might be a single number of the practices using laser, which they don't know what they're losing. But that's the how it's in UK, unfortunately.
We touched on, so obviously most of the discussion that we had, it was about the water lace, the erbium chromium technology. We just mentioned the diode lasers. Can you give us a short description of the differences between these two in terms of both use and indications?
Of course. Diode laser absorbs in pigment, which is a hemoglobin and melanin. So therefore can cut the soft tissue. But you can't use a diode laser in hard tissue because not absorbs and the water is there, a small amount of the water, say example, so they will carbonize, will heat up. But
which I suppose excludes it from using on implants as well, right?
Implant, I wouldn't recommend to use at all. Right?
You don't want any temperature.
Yes, we don't want any
around the implants.
Yes. But when using water laser absorbs in hydroxyapatite and water. Of course, tissue has got water, right? So therefore, water laser can cut the hard tissue, which is a hydroxyapatite, and the soft tissue, which has got the water. Blood has got the water. So there's the difference. So we can, with the water laser, for example, chromium or SGG in this case, we can cut both hard tissue and soft tissue. But when it comes to diode laser, we just only cut soft tissue. Having said that, with diode laser, we can give a photobiomodulation, basically releasing the spasm, if I say it that way, and accelerating the healing, basically getting the blood circulation to the round area. And for pain management, I do treat a lot of the TMJ problems with the diode laser. In this case, I'm using 940 nanometer diode laser. So releasing all the spasm, muscles, pain and tension, and getting pain-free. Of course, one session will not be enough for TMJ problems. It's a setting, so we have to follow. We have to get the initial pain and then stimulate, get the ATP, which is the energy for our cells, mitochondria, to the side, and gradually treating the ganglia where the pain comes from.
And I would like to specify that lasers and red light, although a laser, it's a diode, and there is also diode technology, diode panels is not the same, because laser, about the power, it can penetrate up to 5 centimeters, so it reaches always the muscles. And the diode, mostly for cosmetic reasons, it also stimulates the mitochondria and the ATP production, but it's mainly in the superficial layers, not in the muscle layers.
Yes, that's right. Absolutely correct.
So is it I suppose a lot of people, you said around 10% are using lasers, most of them would have used the diode. Is it because of the cost? Because as we know, there is a price difference between the water laser and the diode lasers. Is it because of the price or is it because of the compliance issues, let's say?
Probably is the cost and unknown, what I will say. So yes, cost, lack of training, lack of national structure and the framework was not there. So therefore, people might not spend in that amount. Whatever my colleagues should know. So this is an investment. This is not just the price on purchase. But as myself seen and all other colleagues I know that has got the laser, if you're using laser properly and every day routinely, they pay off by themselves.
So coming to the return on investment
point,
do you get a quick return on investment on your laser or it takes years to get your money back?
Can you tell me any investment can give a quick results? Have you seen that? Unless you win in the
I have been
lottery.
lucky once.
Yeah.
But
Unless
it's
you
not
win in the
every day.
lottery or you suddenly buy in a stock shares which suddenly jumps. Often investment will take time. In investment, we invest in our patient, we invest in our staff, our members. Laser talks about themselves. I've got the patient from, actually, funny to say that I'm in Netherlands, and this comes from patient coming from Netherlands to me for impacted wisdom tooth extraction. And this patient has got tinnitus because can't use conventional. As you know, with the tinnitus is a lot of the vibration in the air. So she just coming to see me, is a booked appointment, come to see me because impacted wisdom tooth need to be removed.
From a different country. I have heard stories of dentists saying that they have a lot of patients traveling from really far. If the patient is in the south, they have. If the dentist is in the south, they have patients traveling from Scotland or Ireland. But this is on a total different level when you have patients traveling from another country just because
she find me because of my publication. I did impacted wisdom tooth. One side conventionally, which we do normal with
split mouth
technique. One side conventionally, other side with the laser. The laser side we did immediately or day after, patient back to normality with the opening mouth we measuring. I couldn't measure all the measurements.
I was in the other group.
So
when I had my impacted tooth, it was such a tragedy. I couldn't eat for 3 days.
No. So we measured that one. So after even 1 week with conventional side, patient had a limited mouth opening. So that tells that she found me there online and they contacted my practice, Harrow Dental
Very
practice in
interesting,
Hornchurch.
fascinating story.
Yes.
Now, let's peer a little bit into the future. So we've dwelled in the past and in the present, in the future. Where do you see the future of lasers in dentistry? Let's say in 2030. Do you think the penetration of lasers will grow among the UK dentists and globally generally?
Yes, I do. Because now we have got, I think it's about 2030 you mentioned, probably half of the UK practices is going to have a laser one or other way, at least one diode or something like that. You know, today in UK, we have got universities which is taken dentists. Do you know about 60+% of the dentists is a female?
Oh, really? Oh, that's very interesting comparing to implant
So
dentistry.
why all the implant companies starting looking for women dentistry, right? And the women often do minimally invasive treatment. So therefore, companies like BioLase or like other dentists, they should invest a bit time on there. So the next generation, which they doing already, is going to be most of them lady dentists. And lady dentists would like minimally invasive treatment. And why they sometimes fear in oral surgery? Because all the bloods, because invasive of the oral surgery implantology. Imagine we could do minimally invasive. For that reason, where I'm traveling was that lecturing, and I can see how the lady dentist starting becoming more interested from the laser.
Funny enough, our next two guests are ladies, so I'll make sure I'll ask those questions to them as well.
Please
Although
do so.
the topic is not lasers, but I'll probably ask them. Right. We need to draw it to a close. So, as a final question, what advice would you give to UK dentists that are still hesitant of learning about dental lasers?
Of course, I will say there, colleagues, look differently. You want to be the best dentist in your town, in your community. Look investment sides. The laser pays by itself. Most importantly, the patient acceptance. You are the one grade above all other dentists around your neighbors. So they choosing you because they know it's a minimally invasive. Let's look at if you have got any issues or anything nowadays, or want any questions, you will go to AI or you will go to ChatGPT asking the question, right? Olden days, a pencil was my computer. I could delete, I could refresh, I could print. But nowadays, nobody using pencil. Everyone using ChatGPT. When the patient going into ChatGPT, for example, asking where I can minimally invasively treat my 5 years old boy, which has got the decay, as soon using minimally invasively, ChatGPT can give a laser.
That's a good advice. So for those that are already using lasers but not advertise them on their website, it probably might be a good idea to post and talk a little bit more so that ChatGPT can pick up this information from online, I suppose.
Indeed. So we shouldn't be shy talk about it.
Fantastic.
When I bought my first laser, if the patient asked, what's that? I used to explain, what is that? That is a laser. And what can I do? Patient asked, are you doing eye surgery as well? I said, no, I'm doing minimally invasive dentistry. If the patient didn't ask, I used to point out, that is my new toy. And therefore, I did become more recognized. And the people come in for me, my practice, because of the laser.
Fantastic advice. Dr. Aria, thank you very much for your precious advice today. And to all our listeners, I would encourage you, if you're interested in lasers, please look up Dr. Saleh Aria's name, and you can find more information about his courses on his website or on other organizations. He's a lecturer for WCLI and other organizations. So please look him up, and hopefully to speak to you soon in another edition of the podcast. Thank you very much.
Thank you. It's a pleasure to be in here. And I hope my colleagues start looking for that and looking for the end of the day, patient is our center. We should our treatment should become patient-centered.
I hope so as well. Thank you very much.
Thank you again.
Have a nice day.